Me-
Yes, ma'am.
Meena, good evening.
Good evening, one and all. A warm welcome to one and all for this 7th episode of Vivaadham webinar series by the Obstetrics and Gynecological Society of Southern India. This is a webinar series which we have been conducting on a monthly basis. We have taken one particular topic and we have found out what is conventional and what is innovational. So, what are the latest advances? How one treatment modality or investigation overscores or overcomes the other one, and why, how is it beneficial? That doesn't mean that we have to get away with the old one, but there are a lot of time tested procedures, time tested methodologies which have stood the test of time and are still in vogue. This episode, I welcome all of you to this short case scenario where we have a short cervix priming, absolutely asymptomatic, no complaints. She has just gone for a scan, and the scan doctor calls you and says that, she has a cervix of around less than 2.5 centimeter. So it can be 1.5 centimeter, it can be 2 centimeter. So what are the next options that we would be doing for our patients in our clinical scenario? I welcome all of you once again for this episode. Now I request, next slide. Next slide. I will, the coordinators of this Medical Education Committee of Oxy are Dr. Vijaya S. and myself, Dr. Karpagambal Sairam. I request Sampath Kumari Madam, our President of Oxy, to give the welcome address.
Thank you, Dr. Karpagam. See, as she told, this is our 7th Vivaadham webinar series. And thank Dr. Karpagambal and Dr. Vijaya for continuously doing this on the last Monday of every month. This month we have, as she told, the topic is cervical incompetence, which is about 0.5 to 1% with the general population. Most of the time we go with the ultrasound. As per ultrasound, it is 3 to 4% of the population. So once the report comes as cervical incompetence, whether to go with the progesterone or whether to go with the stitch, or now the recent Arabian pessary, whether to go. So now we have 3 wonderful speakers and the moderator who can tell us about the positive and negative impact of all the 3 modalities. So I think all of you will have a good take-home messages and wish all the best for the success of this webinar. And once again, I thank Dr. Meena, Dr. Karpagambal and Dr. Vijaya for this program. Thank you. And I welcome all the speakers and the faculty's delegates. Thank you, ma'am.
Meena, our Secretary of Oxy, she'll be rendering the Oxy prayer now.
Thank you, Karpaham. Oxy prayer. Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you, Karpagam. Over to you.
Thank you, Dr. Meena. Now, the topic is very clear. We have 3 speakers now. Dr. Divya, who is an assistant professor in obstetrics gynecology at ACS Medical College and Hospital. She has got a lot of credits. She's worked in Bombay, she's worked in Ramachandra, and she's special interests are endoscopic surgery and high-risk obstetrics. And a very beautiful Carnatic singer. I request Divya. Please mute others. No, Chitrakala, please. Now, Dr. Divya will be talking about the first topic, cervical cerclage. Over to you, Divya.
Yes, ma'am.
You can share your screen.
Ma'am, is it visible?
You can, you open it, it will be visible.
It's opening.
It's opening.
Visible, ma'am?
Yes. Full screen and you can go ahead.
Divya, go to the slideshow and start.
Yes, yeah. Yes. Good evening to respected seniors and my dear friends and colleagues. At the outset, I'd like to thank you for giving me the opportunity to talk on cervical cerclage today. So, As we all know that prematurity is the leading cause of perinatal morbidity and mortality. And the first cervical cerclage was done in 1902 by Dr. von Fernwald in Germany, further which our own Indian doctor, Dr. Shirodkar, had introduced a standardized anatomical sound reproducible method, which has to be, it has to be done via dissecting the bladder and placement of the knot, which was further simplified by Dr. MacDonald in 1957, which is now widely followed. So who needs a cervical encerclage? It is usually history, ultrasound, emergency cerclage, or transvaginal, high transvaginal cerclage, and transabdominal cerclage, and occlusion cerclage. Usually it is history indicated or ultrasound indicated, or in cases of examination, emergency or rescue cerclage is also indicated. Who will require history indicated cerclages? It is usually done between the gestational ages 12 and 14 weeks and offered to women who have 2 or more preterm births and or second trimester losses, which includes multiple pregnancies and uterine anomalies also, including cervical surgeries like our trachelectomy or LEAP or LETS. So what does the guidelines say? Guidelines say that history indicated cerclage should not routinely be offered to women who do not have these parameters, which are less than 3 previous preterm births or second trimester losses without any additional risk factors. So coming to women with singleton pregnancy and a history of spontaneous second trimester loss, we have to make sure that the cerclage is offered only if the cervical length is less than 25 millimeters or 2.5 centimeters when the gestation age less than 24 weeks. And ultrasound, incidental finding of an ultrasound which shows a cervical length of 25 millimeters is also not an indication to do a cervical cerclage, and it does not recommend funneling of the cervix also in the absence of cervical shortening to less than 25 millimeters also. The cerclage is not recommended. When should an ultrasound indicated cerclage be offered? What does the guideline say? The cerclage is not recommended in women who have a short cervix, which is incidentally identified on a late second trimester ultrasound. It has to be done only on case basis, and it is usually performed between 14 and 24 weeks of the pregnancy. The scan should always be done by a transvaginal ultrasound. Who should be offered ultrasound indicated cerclage? The RCOG guideline says singleton pregnancies, no symptoms, no contractions, no vaginal bleeding, no PROM or no PPROM, and cervical length of less than 25 millimeters before 24 weeks, and previous history of preterm births and previous history of second trimester losses. Rescue cerclage. It is usually done in cases of premature cervical dilatation with exposed membranes in the vagina. It may delay the delivery by about 5 weeks, but there is always a 50% of cerclage failure which can happen, and it also causes a twofold reduction in the chances of delivering before 34 weeks. But the more specific term that is a cerclage, it is that the advanced cervical dilatation, if it is more than 2 to 4 centimeters, or if there is any visible or prolapsed membranes, this rescue cerclage is done as a last attempt. So it is usually placed between 18 and 26 weeks. Emergency cerclage. Emergency cerclage, if it is usually done when we discover on an ultrasound examination of the cervix, or as a result of a speculum or physical examination wherein we see any fetal membranes, exposed fetal membranes, or there is it can be done between or up to 27 plus 6 weeks of gestation. When should an emergency cerclage be performed? It is usually performed between 16 and 24 weeks, and the cerclage is performed when the cervix is already dilated and the membranes are bulging, and usually after a painless cervical dilatation. Transvaginal cerclage. it is usually the McDonald's, which is commonly and widely practiced, which has to be, which is done, it is actually done as a purse string suture at the cervico-vaginal junction without mobilizing the bladder, whereas a Shirodkar requires mobilization of the bladder. There's something called as the occlusion or the worm's cerclage, which is a continuous non-absorbable suture which is placed at the external os. The materials mostly used are muslin or silk. So high risk patients, how are we going to categorize? Who are we going to offer the cerclage? The high risk patients who are previous preterm births or second trimester losses between 16 and 34 weeks, PPROM less than 34 weeks, previous use of cerclage, no uterine anomalies or uterine variant, intrauterine adhesions, and history of trachelectomy. Intermediate risk women are women who have undergone a second stage cesarean section, women who have undergone the large loop excision of the transformation zone, which is more than 1 centimeter. And these women should undergo a single transvaginal cervix scan no later than 18 to 22 weeks as a minimum prior to the cerclage. Special scenarios. In multiple pregnancy, is it a routine? What does the guideline say? The guideline says that RCOG guideline says the cerclage is not recommended in multiple pregnancy outside of a research setting. It is usually given on a case basis. It should be individualized. Cervical surgeries, trauma, and uterine abnormalities. In these procedures, it is uncertain with no additional risk factors. Women should have Mullerian anomalies or previous cervical surgeries, cone biopsies, large loop excision of the transformation zone, or multiple dilatation and evacuation. That's what the RCOG guideline says. What does the ACOG guideline says? It says that cervical cerclage may be considered in women with history of cervical trauma and with obstetric history and mid-trimester cervical shortening. But it is also case individualized. So depending on the surgeries, this is taken from the RCOG guidelines. Depending on the cervical surgeries, if the woman has undergone a cold knife cone biopsy, prophylactic cerclage is significant. It is given, and it is the type of cerclage is history indicated. The timing, it should be between 12 and 14 weeks. Let's and leap procedure, as I previously mentioned, if it is more than 1 centimeter of let's and leap procedure, it is history or ultrasound indicated. It has to be offered between 12 and 24 weeks. Trachelectomy also should be offered. It should be done between 12 and 24 weeks. Whereas simple cervical dilatation or small LETS operation usually does not require a cervical cerclage unless and until it is individualized. When should a trans-abdominal cerclage be considered? In women with previous unsuccessful transvaginal cerclage, previously if she has had a loss, insertion of a trans-abdominal cerclage may be discussed and considered. So abdominal cerclage can be done prior to the conception also. Preconceptional procedures may be more effective and are not associated with subfertility. And mostly all the trans-abdominal cerclages should be offered cesarean birth, and the suture need not be taken out after the cesarean. Contraindications to cerclage, as we all know, it is active preterm labor, chorioamnionitis, continuous vaginal bleeding, and PPROM, any fetal compromise, any anomalous babies, and after any procedure, 2% of miscarriages should be informed to the patient. Investigations, as we all know, the routine investigations has to be done. The CBC, urine routine culture, HVS, cervical length by a transvaginal ultrasound is a must. Ensure that if the patient is taking any heparin or aspirin, she has to stop it at least 3 to 5 days prior to the procedure. Early anomaly scan to make sure that gross anomalies are ruled out, and first trimester and screening for aneuploidy is also must. Should amniocentesis be performed routinely prior to the cerclage? No, insufficient evidence has been given, and both the Royal College of Obstetricians as well as ACOG supports this, and they say that in selected cases when there is suspicion of intraamniotic infection, amniocentesis may be performed to aid the decision about emergency cerclage, and it also comes with chances of miscarriage and a poor prognosis also. Should pre and post-operative tocolysis be used for insertion of cerclage? Peri and pre-operative tocolysis we are not using, but there is no evidence. And even now, the RCOG and ACOG, they say that routine use of tocolysis after cerclage, including bed rests, is not routinely practiced or given to the or told the woman. It should be individualized and case based. Bed rest routinely not recommended. Both RCOG and ACOG, they say that bed rest in women who have undergone cerclage should not be routinely recommended, but should be individualized. Sexual activity. The RCOG and ACOG have different thoughts on this. RCOG says that it does not provide a specific statement on sexual activity and restriction post-cerclage, whereas the ACOG, it says temporary abstinence from sexual activity for a short period of often 1 to 2 weeks is offered to the patients who have undergone cerclage to reduce the risk of infection and disruption of the cervicals or disruption of the cerclage suture, uterine irritability. And role of post-cerclage serial ultrasonographic surveillance of cervical length. It is usually not recommended for a routine serial cervical length measurements after cerclage. The guideline notes that cervical length measurement is most useful prior to the cerclage and not post-cerclage. Post-cerclage is generally symptom-driven, like vaginal bleeding, contractions. If you feel, this is also individualized according to the RCOG. Serum fibronectin testing, whether it is useful. No, it is generally not recommended, not useful. Management should always be based on clinical findings rather than biochemical testing. Progesterone supports. Routine use of progesterone supplementation following cerclage is not recommended, and we have our current nice guidelines also, which says that do not advise progesterone administration following cervical cerclage. What does the Cochrane review say? Progesterone reduces the preterm birth in women with a short cervix or prior preterm birth. In women who have already have a cerclage, there is no consistent evidence that adding progesterone provides additional benefit in unselected populations. Thank you.
Thank you, Dr. Divya.
Thank you, ma'am.
That's about cerclage. Now we'll go to Dr. Jayamala. Can you stop sharing the screen, ma?
Yes.
Okay. Dr. Jayamala is a very good friend of mine. You know, she's from Salem and she has a vast experience in using Arabian pessaries. So for this scenario, let's hear from Dr. Jayamala what she has to say about in favor of pessaries.
Just a minute, sir.
Yeah. She's from Salem. She's working in Rainbow Hospital and a very good clinician and academician.
Jesus, why this is not sorry.
We can see your slides.
Guys, no, it's not coming from the beginning.
You can minimize and go to top and then come.
It's just my iPad is a little bit temperamental. Sorry. Yeah, a little bit more. Sorry, it's loading, I think.
Yeah. That's why it's taking some time.
Sorry, just give me a minute.
Yeah.
So I think my previous speaker had, first of all, good evening, everyone. I would like to thank Dr. Sampath ma'am and Karpahambal for giving me this opportunity. My slides are visible, Karpaham?
Yes, you can go ahead. Yeah, you can go ahead.
Okay, so my previous speaker, Dr. Divya, has already elaborated on preterm delivery and she had given, I think, everything about cervical cerclage, pre, post, everything she had spoken about. So I'll just skip these slides. So, yeah. So let me just go through with this. The rate of spontaneous delivery at or before 32 weeks, according to the cervical length at 23 weeks. So I presume that you had given the topic as primary short cervix. So I took the liberty for twins and singleton. So when the cervical length is less than 20 millimeter at 23 weeks, the risk of preterm delivery before 32 weeks increases. But whereas in twins, even if the cervical length is less than 30 millimeter, the risk increases. So we are keen here on the twins. So there was a study done on the cervical length measurements and the pattern of the cervical changes. So before we go into this, let us understand how the cervical length behaves on a twin gestation. So there are 4 patterns of change in the cervical length, which was measured by ultrasound. The pattern 1 is a stable cervix. 44.4% of the twin gestation follows this pattern. That's a stable cervix. The cervical length measures the same throughout until 28 weeks. That is the stable cervix. Pattern 2 is early rapid shortening, where 4.1% of the twin women should follow this pattern, where the shortening of the cervix is so fast up to 28 weeks. So these are the women who end up in preterm delivery before 28 weeks. There's a pattern 3, which is late shortening, where the cervix remains the same until 22 weeks. And after that, it starts shortening at a rate of 3 millimeter per week. 24.7% of the women follow this pattern. Pattern 4 is early shortening, and then it remains plateau. So this is pattern 4, and 26% of the women follow this pattern. So when you can see, the early rapid shortening is the one, those go into for preterm delivery before 36 weeks. And the next one is the, early shortening with a plateau. So with that, the early and rapid shortening cervical length has the highest rate of preterm birth, less than 34 weeks. So this we are already spoken, but the cervical cerclage, we know it is operator dependent. It requires hospital admission. It needs anesthesia, possible tocolysis. Yeah, you need a theater and instruments. And again, the complications of cerclage, you have the anesthetic complications, cervical trauma, bleeding, premature rupture of membranes. You may trigger preterm labor, bladder injury. There's an increased cervical laceration or trauma if the patient goes into labor with suture in place. Sometimes you need anesthesia for high cerclage stitch removal. So these are the complications with cerclage, or the difficulties with cerclage. So what is new? The Arabin pessary. It is a non-medicated, non-surgical, flexible silicone ring for cervical incompetence. The robust research investigated an alternate treatment for cerclages, which is the Arabin pessary. And in recent studies, Arabin cervical pessary showed promising results across the world. So I'm sure everybody would have seen the Arabin pessary. The indications for Arabin pessary, a previous history of mid-trimester loss or a preterm delivery, cervical shortening by ultrasound, uterine anomalies like septum, unicornuate uterus you can use, over-distended uterus, prolapse, when there is signs of physical strain. So the contraindications, do not insert if confirmed rupture of membranes, symptomatic of preterm labor, if there is vaginal bleeding or suspected choriamnionitis. So Arabin pessary has been approved for the prevention of preterm birth in Europe, whereas in US and Canada, the pessary is given an FDA approval only for investigation or research purpose. So what does the literature say? It was a PSEP trial which done a study on cervical pessary in pregnant women with a short cervix. This shows that the cervical pessary use definitely prevent preterm birth in a population of appropriately selected at-risk patients. 385 pregnant women with a short cervix were assigned to the pessary, 192 for pessary and 193 for the expectant management group. And this study found out that spontaneous delivery before 34 weeks was significantly less frequent in the pessary group than in the expectant management group. So PSEP trial twins, the cervical pessary to prevent preterm birth in twins with a short cervix. This again concluded that the insertion of the cervical pessary definitely reduces the spontaneous early preterm delivery with short cervix. Cervical pessary for preventing preterm birth in singleton pregnancy. This is a meta-analysis which showed that a cervical pessary compared with no treatment or vaginal progesterone may reduce the risk of delivery before 34 weeks or 37 weeks, although it should be viewed with caution. So efficacy of cervical pessary versus cervical cerclage in preventing spontaneous preterm delivery. Again, this showed that compared with transvaginal cervical cerclage, use of a cervical pessary may decrease the risk of PPROM and premature birth before 34 weeks. Given the advantages of easy to use and minimal problem with cervical pessary, it becomes a useful preventive intervention that deserves widespread clinical application. So what does the RCOG say? Should women be offered an Arabin pessary or progesterone instead of a cerclage? So there is no evidence that either progesterone or Arabin pessary alone are more or less effective than cervical cerclage. So again, the PSEP twins, it had concluded that the insertion of cervical pessary was associated with significant reduction in the spontaneous preterm birth rate. So how does the pessary act? See, the pessary shifts the cervix posteriorly to deviate the uterine load. So placement of the pessary lead to or make an acute uterocervical angle. So it takes away the direct pressure on the membranes at the level of the internal os and on the cervix itself. See, another hypothesis is that the pessary protects the cervical mucus plug by supporting the attachment of the remaining cervical tissue. So it takes off the load and it protects the cervical mucus plug also. So there are, I don't know whether you're able to see, I have the pessary in my hand. There are 3 sizes available, small, medium, and large. The outer diameter ranges between 65 to 70 millimeter. The inner diameter from 32 to 35 millimeter, and the height is 17 to 30 millimeter. Can you see? Hello.
Hey, Mala, we can see.
Yeah, you can see. Okay. So, yeah. So that is the outer diameter is 65 to 70. The inner diameter is 32 to 35, and the height is 17 to 30. So this has perforations. This enables flow of vaginal and cervical secretions. Okay, and it is meant for single use. There are different sizes available, as I already mentioned. The recommended sizes when you're using it for first trimester, usually, which we don't, for a short cervix, for singleton, you use 65, 17, 32. For twins, 65, 21, 32. In second trimester, with or without Y-shaped funneling, you use 65, 21, 32. And for twins, 65, 25, 32. If there is a U-shaped funneling, you use a bigger size, 65, 21, 35 or 65, 25, 35. So these are the recommendations for the sizage. So how do you insert it? So you just flex, this is silicone, which is very flexible. You just flex it like you use the prolapse for, pessary for prolapse. You just squeeze it in and you can see that the cervix comes all around the, the pessary should come all around the cervix. So let me see. No, I'm not able to get the video, sorry. So I'll just show it. You squeeze it and insert it and make sure, so as you go to the posterior fornix, just release it and the cervix snugly fits into the pessary. So make sure, put your finger in and make sure that this pessary is fully around the cervix and then give a push, to the posteriorly so that it goes and towards the sacrum. So that is how you put it in. And then you can do vaginal ultrasound with pessary also. You can measure the cervical length with the pessary. Usually I don't see any problem in inserting. And when you have to remove it, you just put your finger in. Because you're leaving it for so many weeks, there could be edema, so you just put your finger in, release the cervix from the pessary all around, and then squeeze it and take it out. This is how we remove it. So after all this, I'll just go with my experience with Arabin pessary. So indications when I use it, when it is singleton with a previous history of second trimester loss or a previous early preterm delivery, when there is ultrasound evidence of short cervix with or without funneling, emergency or rescue cerclage for open cervix along with the cervical encerclage. So whenever there's an emergency cerclage, yes, our first option will be cervical encerclage. Along with the cervical encerclage, I put in the pessary. And congenital anomaly of the uterus, like if the patient had a septal resection or if the patient had a uniconvate uterus, I use pessary. For twins, IVF twins. Routinely, I use for IVF twins or other twins with ultrasound evidence of short cervix or emergency or rescue cerclage for open cervix along with the cervical encerclage. So before prophylactic insertion, I do a 12-week NT scan and a combined test, do trisomy screening, make sure that the trisomy screening is negative, treat for bacterial vaginosis. I give clindamycin pessary for 1 week PV, and then I insert it at around 14 to 15 weeks. Post-insertion, definitely I put them on micronized progesterone, 200 milligram BD per vaginal, and I remove the pessary at 36 to 37 weeks or before if they come in labor. So results, I mean, I didn't do it as a study. Because someone asked my experience, I just, with the data I had, I've compiled everything and putting it here. So it was three years from November 2022 to October 25 and until today, I have inserted 51 pessaries. So for twins, 25 and for singleton, 26. Of the twins, prophylactic 17, emergency 8. Most of the emergencies have been sent to me, they have been referred to me for the cerclage. So singleton 26, history indicated 15, ultrasound indicated 6, and emergency 6. So pessary alone, I've done 35, cervical encerclage with pessary 16. So even with this kind of things, prolapsed, I mean, bulging membranes we have done. Let me just skip these. So the results, the mean age of patient in years, 28.29 years. Gestational age of insertion, 11 weeks to 28 weeks. Change in cervical length before and after procedure. I don't have data on all patients, but whatever I had, we get, sometimes we get on an average 1.2 centimeter more. The gestational age of removal, 36 weeks in singleton. So outcome with pessary, singleton, more than 36 weeks of, only I think 4 of them had to have, we had less than 36 weeks. The rest of them are above 36 weeks in the singleton. That 36, less than 36 weeks, most of them are emergency cerclage, which was done, emergency cerclage with pessary insertion. Twins, most of them were delivered after 34 weeks. Only 4 had to be delivered before 34 weeks, of which 2 went into labor. 2 was for not for preterm delivery. I think it's for preeclampsia. Yeah. See, outcome with pessary, the singleton, the mean gestational age was more than 36 weeks, of which normal delivery 10, cesarean 7, 2 were expelled. I think that was an emergency cerclage, advanced 2 to 3 centimeter dilatation, it was done. So 2 were expelled and 4 are ongoing. Less than 36 weeks, 1 was normal delivery, 2 was cesarean. Twins, the mean gestational age was more than 34 weeks. Of course, they're all twins, so almost everyone ended up in cesarean. 1 got expelled, 4 ongoing. So less than 34 weeks, as I said, 2 went in for preterm delivery. They were both were emergency cerclage done at a later gestation age, and 2 were for not for preterm delivery. Sorry. So patient's perspective, the Arabian pessary is comfortable, painless. They are able to carry daily activity. So they found improved quality of life. From our perspective, it's an easy learning curve. It's non-invasive. It is operator independent. No need for anesthesia or operation theater. Can be done as an outpatient procedure, and procedure time is less. So far, I haven't come across not able to put in a pessary. I haven't come across that kind of a situation. And most of the times, There was no side effects. Most patients complain of increased vaginal discharge, which you have to inform them beforehand. Only once I had to remove and wash it out and reinsert it because the patient came in saying that she has leaking, but it was actually vaginal discharge, copious vaginal discharge, that I had to take it out, clean it, and then put it back. And once after emergency cerclage with pessary insertion, the patient was complaining of not able to pass urine. So I had to put in a catheter and leave her for on catheter for almost 4 weeks. That's the only problem I faced. So conclusion. So in developing countries like India, there's an urgent need for low cost, low technically preventive interventions that can be applied easily by trained health practitioners to reduce the burden of preterm birth and associated neonatal morbidities. Thus, Arabian cervical pessary is safe and effective in prevention of preterm birth due to cervical incompetence and has better overall performance and could be a best alternative to cerclage. Thank you.
Thank you, Dr. Jayamala. Thank you so much for sharing your experiences with Arabian pessary.
Thank you.
Definitely, I think we really have to start considering it on a larger note, I believe. Okay, now I request Dr. Archana.
Hi.
Hi,
Yeah.
Dr. Archana is a fellow in gynec laparoscopy from Aster Medicity, Cochin. So she's going to tell us about the most, and again, time-tested tocolytic called progesterone. So she's going to say about the role of progesterone in short cervix. Over to you, Dr. Archana.
Thank you. Good evening, everyone. I would like to begin by thanking Dr. Karpambal and other organizers for giving me an opportunity to speak in this webinar. Today, I'm going to speak about the role of progesterone in short cervix. So, defining short cervix means the cervical length less than or equal to 25 mm measured by transvaginal ultrasound between 16 to 24 weeks of gestation. And gold standard is the standardized TVS technique with an empty bladder, but it can also be measured by transabdominal ultrasound in a partially full bladder. So short cervix is a risk factor for spontaneous preterm birth. Also, it has a high predictive accuracy, positive predictive value of 70% in short for the preterm birth. And it has a 60 to 80% detection rate of spontaneous preterm birth. But coming to normal cervical length, it shows only a 4% risk of delivering by preterm delivery. So there are several studies showing the clear association of short cervix and preterm birth. Coming to the physiology of the progesterone, there are several mechanisms of myometrial quiescence. First one is a gap junction modulation. So progesterone reduces the gap junction between the myometrial cells and thus reduces the prostaglandin synthesis. Also, it prevents the coordinated contraction. Progesterone also has anti-inflammatory effect. It suppresses the inflammatory cytokine expression, interleukins, matrix metalloproteinase, etc., and this reduces the pro-inflammatory cascade associated with the preterm labor initiation. It also regulates the cervical integrity by collagen remodeling and maintain the stromal structural integrity, and thus delaying the premature cervical ripening. Coming to the functional progesterone withdrawal, it's not the serum progesterone withdrawal, but it's the changes in the progesterone receptor activity that is contributing to the cervical ripening and the labor onset. So the type of the progesterone we use in the clinical use are natural progesterone, which is similar to that produced by the body, and it's commonly administered as a pessary or a gel. And there are semi-synthetic progesterone, which has a different chemical structure, and it includes 17-hydroxyprogesterone caprate, which is given as a weekly intramuscular injection. There are several formulations of progesterone. The vaginal micronized progesterone, which we commonly use, is available as a capsule or a gel. It's a 200 milligram capsule or a 90 milligram gel. And 17-alpha-hydroxyprogesterone caprate is an intramuscular injection, which is given as 250 milligram IM weekly from 16 to 20 weeks up to 36 weeks of the gestational age. And oral micronized progesterone is also available. It's also 200 milligram daily, but it is having a poor bioavailability. Therefore, it's not recommended. Vaginal progesterone is always superior to oral, and it's having a good bioavailability according to the evidence-based medicine. So it is the first choice, vaginal progesterone. Coming to the timing, we start when we detect the short cervix on ultrasound. When the short cervix is detected less than or equal to 25 mm, when it is identified at 16 to 20 weeks, we start and we continue till delivery or till the 36 weeks, whichever is earlier. Side effects are very common. Side effects are irritation or discharge. They can be breast tenderness, headache, mild drowsiness. They can be rare side effects like with IM form, with oil cyst formation or local infection. Coming to, there are several randomized control trials showing the effectiveness of the vaginal progesterone in the short cervix. Coming to the EPIC meta-analysis, this is it's a meta-analysis of individual participant data from a randomized control trial. It is published in Lancet in 2021. So its recommendation is high-risk singletons. The recommendation is women with previous history of spontaneous preterm birth or a sonographic short cervix. It should be offered daily vaginal progesterone or weekly progesterone injection, IM injection to prevent preterm birth. But in a patient with a normal cervical length with the previous spontaneous preterm birth, there is uncertainty regarding the use of the progesterone. This is the optimum trial. This is also published in Lancet. Vaginal progesterone prophylaxis for preterm birth. This is a multi-center randomized double-blind trial. So it says its recommendation is singleton gestation with short cervix. Progesterone, vaginal progesterone reduces the preterm birth risk. And they also recommend the universal cervical screening along with the progesterone in short cervix reduce the preterm birth rate. So these findings support that implementation of the cervical length screening program with targeted progesterone intervention for the preterm birth prevention. This is a nice 2022 updated guideline. This they say they offer a choice of prophylactic vaginal progesterone or a circlage to a woman having a history of preterm birth or a second trimester loss and a transvaginal sonography showing a cervical length of less than 25 mm or less. So if both are there, if there's a strip preterm birth and if there is a cervical length of less than 25 mm, then we can offer either progesterone or circlage according to NICE. And they say is only licensed preparation of progesterone is vaginal 200 mg capsules. But we can consider the use of prophylactic vaginal progesterone if either one of them is there. If there is a strip preterm birth or a second trimester loss after 16 weeks, or if there is a TVS showing a less than 25 mm of cervical length, we can consider prophylactic vaginal progesterone. And they also say start from 16 to 24 weeks and continue till 34 weeks. This is a prolonged study. This is an RCT. It's a multi-center international RCT, double-blind trial it's called prolonged trial. Its conclusion is 17-hydroxy progesterone to prevent the recurrent preterm birth in singleton gestation. So its conclusion is in women with a prior spontaneous preterm birth, weekly hydroxy progesterone compared to placebo did not reduce recurrent preterm birth. So, according to this study, 17-hydroxyprogesterone is not recommended for the primary prevention of preterm birth. So, they actually, FDA in 2023, April, they withdrew 17-hydroxyprogesterone from the market. This is a pregnant trial. This is the latest trial, 2024. It's a vaginal progesterone to prevent the spontaneous preterm birth in women with a sonographic short cervix. So this says that asymptomatic women with a short cervix of 10 to 20 mm is given a placebo and a vaginal progesterone gel, 90 mg daily. So this showed a lower rate of preterm birth, less than 33 weeks in the progesterone group. Coming to a different clinical picture of multiple pregnancy. So the challenge in the multiple pregnancy, preterm delivery is more common in multiple pregnancies. And even without PPRO, spontaneous preterm labor is the most common etiology. So the current evidence is there is no proven prophylactic measures exist to prevent spontaneous preterm birth in twin gestation. And there is circulation paradox also. In twins with short cervix, if it is less than 25 mm, and cervical circulation increases the risk of early preterm birth. So it's contraindicated. FICO says there is limited evidence in twins. Unselected multiple pregnancies, progesterone therapy is not recommended. In high-risk multiple pregnancies with additional risk factors like history of preterm birth, the effectiveness of progesterone therapy remains unknown. So these are the evidence from the various trials and meta-analysis. The pregnant trial says vaginal progesterone reduces the preterm birth. There is 45% reduction in the preterm birth less than 33 weeks. ACOG also and Society of Maternal-Fetal Medicine also recommend vaginal progesterone. But according to the prolonged trial, 17-hydroxyprogesterone was historically used and it was no significant benefit. It's no longer recommended by FDA. And multiple gestations, there is no proven benefit of progesterone. So not routinely recommended. So these are the several key clinical evidence. According to Faucier and Hazen, preterm labor less than 34 weeks reduced with the vaginal progesterone from 19 to 8.9%. And Hazen et al. Showed a preterm birth reduction of less than 33 weeks reduced by 45%. Prolonged trial as already mentioned. In Cochrane review also, vaginal progesterone reduces preterm birth less than 34 weeks by vaginal progesterone. So this is a campaign to vaginal progesterone circulation in the prevention of preterm birth. It's a meta-analysis. So this is published in AJOG. So this says the campaign treatment of circulation and vaginal progesterone could result in a greater reduction in the preterm birth compared to single therapy. When we compare the pessary with the progesterone and circulate, it's a support trial in a woman with short cervix. Conclusion was that for women who develop a short cervix, circulate, pessary, and vaginal progesterone were equally efficacious at preventing the preterm birth, as judged with a 20% equivalence margin. So if given a scenario, singleton with no prior preterm birth, and cervical length is short cervix, cervical length is less than or equal to 25 millimeter, then we recommend vaginal progesterone. If there is a history of prior preterm birth with the cervical short cervix less than or equal to 25 mm, then vaginal progesterone is recommended. But if there is normal cervical length with a history of prior preterm birth, we can consider vaginal progesterone, and multiple gestation, it is not recommended. So these are the guidelines, says ACOG, vaginal progesterone, not for multiple gestations. Similar recommendation by Society of Maternal-Fetal Medicine. NICE recommends 200 milligram daily of progesterone if cervical length is less than 2.5 centimeter. And WHO also says vaginal progesterone for the prevention of preterm birth in short cervix. So the key points are the screening is a key of between 16 to 24 weeks. And vaginal progesterone always demonstrate a superior bioavailability and tissue-specific delivery compared to oral formulations. And progesterone is not a tocolytic; it only has an anti-inflammatory property, and it reduces the risk of spontaneous preterm birth and neonatal morbidity. Offer vaginal progesterone if there is history of a prior preterm birth and/or sonographically short cervix. Thank you.
Thank you, Dr. Archana. That was very nice about progesterone because we have been misusing, abusing progesterone left, right, and center. And I think definitely has a role to play in clinical practice. Now I request Vijaya Madam. Vijaya Madam is the coordinator for Medical Education Committee to introduce our moderator, Dr. Prashant Adiga.
Yeah, this is really, it was a very nice presentation by all the three persons. And in fact, all the three are very contradictory and confusing for the consultant. Some people use all three also, whatever the benefit or, but then we should also know which cases to select, and all the trials and evidences are very nicely done by all of them. And of course, there will be lots and lots of questions will be there. And to clear all our doubts, we invite Dr. Prashant Adiga, Professor Head of the Department of the Reproductive Medicine and Surgery, KMC Manipal, Imaging Science Award he has got in 2000. 2007. He got a fellowship in advanced OG at Mediscan at 2007 and fellowship in reproductive medicine at KMC Manipal at 2017 and many national and international publications, and he has contributed to many chapters in textbook, and he'll be the best person to tell us the correct points which to use and when to use and where to use. Over to Dr. Prashant, sir.
Thank you, madam. At the onset, I would like to thank Dr. Sairam for giving me this opportunity to moderate this session. I had few points to make. This is first about the cervical encerclage. Now, to put a cervical encerclage beyond 20 weeks would be a challenge. I'm sure many people would have done this. It is something like putting a needle through a butter. Many times the cervix is very fragile. That is a challenge which I have faced in a couple of patients. So beyond 18 to 20 weeks, I do not put a cerclage. That is my point. Second thing is, the problem about diagnosing short cervix is most of the times there are no risk factors. Suddenly you see then you have short cervix. We have had a lot of problems because the patients we attend to are all, most of them are working mothers. So we have universal screening program where at 12 weeks during the time of NT scan, we measure the cervix. And then every 3 to 4 weeks, we keep measuring the cervix. I think the point which Dr. Jaimala made, the 4 patterns of the cervical changes, probably we should be able to identify those late changes, which I think that is where we are trying to indirectly find out. That is the second thing. Most of the times, suddenly at 18 weeks, you find a short cervix. What next? That is the problem. Now, the third thing is about the speciary. Madam, I would like to ask your opinion. Yeah, you have put Arabian pessary when the cervix is dilated?
Yes, sir. Like when the cervix is dilated, obviously I believe in cervical cerclage. Along with the cerclage, I put in the pessary. But
okay. The reason why I'm asking you this is because we do not know which of the 2 components have impacted or which have brought in the results. Is it the encerclage or is it the pessary?
But I have
my point.
I have inserted the pessary for women who had a cervical encerclage before and then comes in at say 26 weeks with open cervix. At that time, I had put in a pessary and that worked.
Okay, fine. So, and regarding the progesterones, now there are, as Dr. Sairam said, that progesterone have been used or abused. There's hardly 2 words, AB, if these are 2 words which have to be either added or subtracted, basically. Now, Dr. Archana, there are many progesterones. Now people are coming up with dydrogesterone saying that you continue till 20 weeks, it is supposed to prevent short cervix. What is your opinion? You have to unmute your, please unmute yourself.
Unmute Dr. Archana.
Yeah, so only vaginal progesterone is recommended. Vaginal micronized progesterone, 200 milligram, according to the guidelines.
Yeah, that's right. And even nowadays, there are companies who are coming with oral micronized progesterone saying that it is efficacious. But again, time is going to tell. But the problem with oral micronized progesterone is that it cannot avoid first-pass metabolism. The amount of progesterone which are reaching the uterine circulation is in a minuscule concentration. And third is the problem with oral micronized progesterone is about the ability that it can cause intrahepatic cholestasis of pregnancy. Now the first question is, what is the best treatment for short cervix? Now, I am the odd man out here because I have been asked to judge. I would not say judge, but I would say rather probably which is the best modality of treatment. Now, I would like to share, I think this is already mentioned by Dr. Archana. I think, yeah. This is a support trial where they say that, it is a multicentric randomized control trial where, they have compared cervical encerclage, pessary, and vaginal progesterone. And they have found that all the 3 are equally effective. Before this, we had a problem. We didn't know which one was a better thing. Then there was a, network meta-analysis, where they have compared cervical encerclage with progesterone. Again, they have said that progesterone should be the first one to go about. So that is the thing. And one word about, finally, it is your experience which matters. I'm unable to.
Please, others, please mute yourselves. Sir is talking. Please.
Yeah.
Dr.
Now,
N.S.
finally, it is
Mahalakshmi.
your individual, because when all the three, modalities of treatment are giving equal results, probably it depends upon your individual experience. Now, there are certain things which I would like to make. Now, in a patient with a history of, dilatation evacuation, I personally feel that termination of pregnancy in the first trimester should be always by medical means. Even now, people go ahead with dilatation and evacuation, which is a risk factor for short cervix. Probably this is one message which I would like to tell. And then the second point which I would like to make is problem with abdominal cerclage. I have a patient who has had, first one was a preterm delivery at 27 weeks. The second one was a failed McDonald's suture. Now, the patient has now gone directly for abdominal cerclage. Now, she is 35 years, her AMH is 0.7. Now, I have a doubt, if I go for IVF, will I be able to negotiate the internal loss? Because I have never seen one. I mean, this is one problem which I think I'll have to, I don't know if I'm, I have never seen anybody with encerclage, because what we do is, in case McDonald's stitch fails, we go for a more physiological, that is the Shirodka stitch, which has been quite effective. Although I do not have any studies comparing it with abdominal cerclage, but Dr. Divya, in case somebody has undergone abdominal encerclage, will we be able to do a embryo transfer? This is my question to you. Will we be able to negotiate the internal loss? Because basically the internal loss.
Yes, sir. I have not been doing any IVF procedures. I don't do embryo transfers.
Okay.
So I am afraid I don't have an answer.
No
to
problem. Anybody can.
Failed cerclage means already it has loosened and then the fetus is expelled through vagina. That's what, if it is not an hysterectomy, if it is expelling out through the vagina, definitely you should be able to do the embryo transfer in the next time because of the failed cerclage.
Yes.
No, she already has the abdominal cerclage. Interpregnancy. Yeah.
Interpregnancy. Oh, yeah.
Abdominal cerclage
Interpregnancy.
it can be done, sir,
Excuse me,
because...
Dr. Karpadammal.
Yes.
Can I speak?
Yes, please.
I'm Dr. Shamima.
Yeah.
Because I heard a doctor is asking this question whether we can do a embryo transfer after abdominal cerclage. I had a patient who had a very short cervix, previous failed cerclages, and I did an interval abdominal cerclage, laparoscopic cerclage, and followed by we had an embryo transfer, which was very easy, and she conceived and she has delivered, and I have kept the cerclage in situ.
Yes.
So that she has embryos. So that is my experience. So I thought I will share it.
Thank you for your
Thank you, Dr. Shamima.
valuable information which you have shared. But at the end of the day, all the three are equally effective. So it depends upon your personal experience, what you would like to do, and what is your interest. Fair enough. I think all the three are good enough. So, and then probably it is important that we talk to the patient. That is the most important. Unfortunately, present day, people do not talk. One of the complaints what patients have is that they do not, the doctors do not spend much time with the patients. That is where most of our problems can be solved. And with these few words, I think I conclude that all the three speakers were good and all the three modalities are equally good.
So one thing I want to add on here, sir, like you said you didn't mention about the twins, where most of our twins are IVF twins. Already these people have spent so much of money. So I think this pessary, I mean, people previously, before pessary, I was using only progesterone, but once the pessary is here and it is cost effective compared to, you have to cater to preterm babies. So when you compare,
absolutely, I totally agree with you. When they have spent about 1.5 to 2 lakhs, spending 9,000 or 10,000 wouldn't matter. But as you see, I do cater for IVF pregnancies, where a small percentage of patients do, we do their antenatal care. As you said, they are at a higher risk of having preterm delivery. And probably now I can always take a leaf from Dr. Jaimala's book to use the Arabian pessary.
Jaimala, I have a doubt. Jaimala,
yes,
I have a small doubt, Jaimala. Suppose you have kept in Arabian pessary, how do you screen the cervix?
It is
Dilatation or shortening, nothing can be seen, no?
it's
no, you can do scan along with the pessary.
scan.
You can
But it is stuck to the cervix, no? That length can be seen.
no,
But
yes,
it will be seen as a
the cervix is inside here.
yeah, it will be seen as an echogenic line, madam. The pessary will be seen an echogenic line.
Yes.
That echogenic line, that small area, we will not see on scan, but above and below it, we will be seen. And if there is funneling, we will be able to measure, madam.
But length cannot be measured, no? Maybe dilatation and funneling can be
Can
measured.
be measured, madam.
Can be measured, ma'am.
It'll
The
be
study includes
2D scan. 2D scan, the whole pessary will appear as a echogenic line on a 2D plane. So we measure it above it and below it, the cervical length, from the internal loss till the external loss. So it is possible, madam.
Possible. Okay, don't have experience.
So that I have a question for Dr. Jaimala. Do you prophylactically use pessaries for the twins without short cervix, without history?
Yeah, that's what I said. Only for IVF twins.
Oh, sorry. Okay, I
Because
don't prophylactically use pessaries unless
I presume this 34 to 36 weeks is that area that I think this prevents. Once I put in a pessary, most of the times I'm able to carry on up to 36 weeks. That 34, maybe with progesterone, I was going about 34 weeks plus. But my NICU takes up any babies less than 36 weeks. The NICU takes. So I presume that this works for them.
Yeah, I completely agree. The problem here is we are not using only one modality of treatment. We are combining many modalities. When we combine many modalities, we really won't be able to give a clearer picture of what worked and what did not work.
Absolutely.
So that is the reason why we are here to say whether, are we done with doing cerclage alone? Are we done doing with pessaries alone? And are we done doing with, are we happy with the progesterones alone? So the whole thing here is, so the combining modalities, we are not able to give a clearer picture. And as long as the patient reaches term, we are happy. But now, isolated
short cervix.
what we are hoping for.
Isolated short cervix, you have to observe only, no need for anything.
No, Karpagamal, like what happens is I don't give pessary for twins who are conceived by either ovulation induction, spontaneous or IUI. Sometimes when they come in preterm delivery, my staffs used to ask, why did you not give pessary for the patients? So I feel guilty sometimes.
Okay.
What is the chance of expulsion rate?
Sorry,
expulsion of the pessaries.
Yes, I've never come across expulsion. Only when the patient is going into labor, and if she comes in advanced labor, it is just lying in the vagina.
Oh.
Okay. See, I have had a patient who had expelled with the pessary. So, I mean, I have had patients who delivered with they went to term till pessary. So the whole thing about it's always cervix is a very dynamic organ. Today it can be short, tomorrow it can have 1 centimeter extra length. And lot of factors are there, like pelvic pressure, constipation, anything can be. I have had patients who had absolutely 4 centimeter cervical length 2 weeks back, and actually 2 weeks later they come with an open nose. We put them head down and try to push them membranes inside with Foley's bulb. So it's a very dynamic organ. So it's very difficult for us to say. The only thing that I feel maybe one of the reasons is because lot of hormonal usage, maybe it decreases, interferes with the collagen matrix or the smooth muscle of the cervix, which has a very, very low smooth muscle component. So maybe in IVF, as Dr. Mala says, she might consider, but I'm one person who don't do anything to twins unless there is an indication like, short cervix by scan or ultrasound indicator or a history indicated cerclage. I don't let them go till, thank God, many of them have come till term cross 36 weeks. So prophylactic cerclage is definitely not indicated
No,
in
yeah.
twins because Dr. Bala is doing a non-intervention, maybe a minor intervention with pessary, and that too, she's not subjecting the patient to anesthesia, not subjecting the patient to any other risks. So she's just inserting a pessary, which is fair enough. And definitely combining it with progesterone and all those masalas.
Yeah, because at the end of the day, patient wants an answer. At the end,
Exactly.
pregnancy has to continue beyond 34 or 36 weeks, whatever is,
Exactly.
And another important point is what we routinely do is look for vaginal discharge.
True.
That is the
Yes,
biggest
yes.
culprit, and you treat it. And then of late, I think better to give probiotics than giving antibiotics.
True, sir. I do.
Probiotics is something
Yes.
which it might help in some ways, because again, if you keep on giving antibiotics, they are also not very comfortable.
Yeah. Correct, sir. Correct. And
there are people who put prophylactic encirclage for IVF twins because, as such, they are at a higher risk. There are people. I'm not saying. We can always agree to disagree. Okay, there are any probiotic is okay. Any probiotic can be given which contains, lactobacillus. No such thing. But basically, you are trying to increase the good bacteria, that is lactobacillus, and trying to prevent the bacterial vaginosis. So that is the thing. But again, as you said, no, it is always important that we counsel the patient and say you need to have a look at the cervix, especially if there are risk factors for shortening of the cervix. Please tell them the importance of those symptoms. Like sometimes they'll have backache. They think it is gas. I don't know in Tamil Nadu, but here they say I had this gas problem. I had backache. In fact, it is the cervix which is shortening. I keep telling them. In fact, one of my patients I had told them that you might have backache and you might have lower abdominal pain or crampy abdominal pain. She was on her way from Udupi to Hassan, and suddenly she started having this backache. She didn't realize. Suddenly she had a brainwave that, okay, my advice. Then by the time she went to Bangalore, there was almost the fetus was in the vagina. Too late. But then, these are some of the things which are important, and documentation of what we have communicated is important because we are in the era of litigation where we don't know who is going to drag us to the court. So document and then, do the cervical screening program. You can always individualize the cervical screening program, like how we do is every, 12 weeks during the time of NT scan, then 16 weeks, then during the time of target scan, and 24 weeks when they come with their GTT. That's the time when we do it and we have an idea. Now, what I'm going to do is, I have, what Dr. Jaimala said, and I think we are going to look at that, the dynamic cervixes, the 4 patterns, so that it will help us in, really knowing who to which category do they belong to.
Yeah.
Thank you for the
Thank you,
opportunity
sir.
you have given, Dr. Sairam and others. Thanks a lot.
Thank you so much. It's a very wonderful discussion, and I am sure we are going to have more innovations coming up, and we are going to talk about the old, the new, the conventional, the traditional, everything, and and definitely we have to tailor make our
Absolutely.
based on the patient's clinical situation and our expertise. And the one Dr. Kameshwari has written that at Fernandez Hospital they had done a study comparing abdominal cerclage with Shirodskas with 90% take-home baby rate in both. So actually, if you are a very good can do a good cerclage that is as good as an abdominal cerclage. That's what they had studied. So from then on they moved to Shirodskas because they did not do a laparoscopic abdominal cerclage or a laparotomy. So basically, so that is actually, so we need to learn technically the skills of doing a proper Shirodhkas technique, because we just have reached the internal loss and just put the thing there. In an abdomen, I have done lap abdominal cerclages where we nicely create a window and go at the level of internal loss and put the cerclage and make sure the knot is placed anteriorly. So regarding removing the knot, actually, as Dr. Divya said, knot need not be removed, but because The menstrual blood can pass through, sir. So because when they do an internal clutch, menstrual blood can pass through, and if the patient wants to have another baby with the same clutch itself, she can have another baby also.
Even
So,
early abortus fetus can come through
yeah,
that.
so very early. So the best thing is, embryo transfer catheters should be able to negotiate through the passage and should not have any problem in the embryo transfer with an abdominal.
The challenge is, in case somebody has a leaking at say 20 weeks or 21 weeks.
That is a problem.
That is where you have a challenge. See, it is always the uncertainty. See, 28 weeks, yes, the viability is good. 800-gram baby or 1 kg baby do survive. But what
Yes,
about the 300, 400? You are in a soup. I mean, you have, you can't, you'll have to go for a, hysterectomy. That is something which
Yes,
is painful.
very, very painful.
Yeah. And what, next time, what is going to happen is that scar is not going to be very strong.
Exactly.
These are the patients who can have, scar descents at a very early gestational age, as early as 34 or 35 weeks.
True, sir.
Somebody wanted to discuss some case.
Dr. Kameshwari, you can discuss the case, madam. Madam, you're...
Yeah, thank you. Can you hear me?
Yes, madam. Yes, madam.
Yeah. So first of all, thank you for the nice session to all the three speakers. I just accidentally saw your Zoom link and registered, but very interesting and good comments from Dr. Prashant also. Recently, we had a case. This lady had a unicornuate uterus. Previous failed McDonald's. Okay. So this time, my colleague inserted a Shirodkar. After Shirodkar, unfortunately, she had bilateral, no, not bilateral, unilateral hydroureteronephrosis. Later on, in 48 hours, we investigated, we found that she had an anomalous ureter with a very low insertion into the bladder, duplex ureters joining just at the insertion, single entry into the bladder, which is so low. So this Shirodkar has kinked it. And then she went into this. Okay, so what they did, they had to remove it, obviously. And then after 3-4 weeks, they put a abdominal cerclage with great difficulty, open abdominal, okay? She has a rudimentary horn on one side and this unicornate, very difficult to put it, but somehow she put it. Now to her extreme bad luck, she had TIFA just 2-3 days back and there is hypoplastic left heart. So, what do? You have to now remove, when we put abdominal, we put the knot anterior. So you can't actually remove it. You have to do a laparoscope to remove the cerclage. And then what do? Do we allow her to deliver vaginally? The cervix is very scarred. You can't hold, you can't do anything. If it tears, the ureter is very close.
Very close.
A lot of dilemma, We gave her one option. I know this is terrible, but if she can continue and we could do a lower segment cesarean and retain the cerclage after 28-30 weeks. But to carry a baby with a hypoplastic is very traumatizing. But hysterectomy is also equally bad at this gestation. So we were feeling terrible, and I don't know how any of you would handle this case.
Is she still continuing? You're finished, madam?
Yeah. At the moment, she's continuing. She's around 22 weeks. She just had TIFA.
Madam, it's legally also very difficult, madam, to terminate after 24 weeks.
Yeah. See, the problem with these abdominal cerclages is removal. Removal if the pregnancy fails.
Correct.
Is a challenge. If you put open abdominal or lap interval, we put the knot anterior.
Yes, madam.
And in open abdominal, we put knot posterior. Okay, that through colpotomy we used to cut and remove. But in lap intervals, we're putting anterior knots.
Madam, I have removed one abdominal cerclage, madam. Actually, the patient said, I don't want any foreign body inside. And she had completed family. I actually, during the time of cesarean section, recently only I did.
That cesarean way, it is easy.
Very easy, actually.
No.
Push the bladder down.
When the pregnancy fails with the abdominal, in the second trimester, you can't deliver her vaginally unless you remove the abdominal cerclage.
Correct,
And
madam.
to remove it, you have to put a laparoscope to cut if it is an interval with not anterior.
Not anterior. Correct, madam.
That is the only problem with abdominal. We moved to Shirodkar long back. We had almost, we did a study. We used to do a lot of open abdominals before. And the study we did had 68 Shirodkar versus 53 trans-abdominal. Okay, and the take-home baby rate, there were 68 pregnancies in the Shirodkar group and 59 in the abdominal. And baby rate take-home is 94% with Shirodkar, 91.5 in abdominal. So when it is equal, we just move to Shirodkar only. We only do abdominal if the cervix is terrible and very, very scarred, can't hold, can't grip. We offer interval lap. I'm sure all of you must be following the same.
Yes, madam.
Thank you. Thank you so much. And I'm very
We
interested in the
just
Arabic
pray that,
recipe.
ma'am.
Very
Ma'am, keep us posted about the case. How did you
Yes,
manage?
yes. I will do that.
Really terrible, ma'am.
Yeah.
Yeah, because it's tough. But maybe you can allow a vaginal delivery, and in the second time you can put a laparoscopic abdominal cerclage.
Yeah.
Because it's already a scarred cervix, you can do
Yes.
that. That is one
See,
option.
they are
Anyway, keep us
heartbroken
posted.
and they're very heartbroken. This is
I
an
know.
IVF pregnancy. And
know,
they
precious,
are
ma'am.
saying we don't want
Very-
another pregnancy.
I know, very tough.
At this
Ma'am.
moment, they are saying that. We had only one case where I put Arabin pessary. She is also very bad obstetric history and IVF pregnancy came with funneling, difficult to put a surplus. So we put an Arabin and pulled her to 30 weeks. 30 weeks she had ruptured membranes, but the baby is fine.
Survived. Okay.
Yeah.
Nice, ma'am.
30 weeks.
Thank you, ma'am. Thank you for the
I agree with
discussion.
the patient consents for a
Yeah.
laparoscopic cerclage
Yeah.
removal possible
Yeah.
and then
Yeah.
has a vaginal termination, madam. I know the
I
historical
know. That's
Yeah.
what.
Yeah.
difficult.
I will let you know.
Yeah. Thank you, ma'am. Thank you so
Thank you
much.
so
Thank
much.
you so much.
And
Thank
thank
you
you
so
because
Thank you,
I think
everyone.
one of them have solved my doubts because I was just thinking whether should we remove this abdominal cerclage in case we are not able to negotiate the internal loss. Anyway, I think madam only has updated us that we'll be able to negotiate the internal loss.
Yeah.
So hopefully, yeah.
Thank you so much.
Thank you, sir.
Thank you.
Thank you, everyone.
Thank you.
Thank you everyone for this very lively interactive session. I think these are the things that we need to understand in clinical practice because how much ever we read, how much ever guidelines we see, how much of evidence we have, what to be done for that particular patient and that situation really makes a lot of difference, on how we practice it. And I know we're all result oriented. We want all the pregnancies to go till term and take over. I always tell my patients, I don't want my babies to go to the NICU. They all go till term. So I'm strongly in favor of single embryo transfer. So I say one baby, you go take till term, then after 3 years, come again. We'll put another embryo inside.
Yeah.
So I think we just have to tailor make our practice based on the situations. And thank you everyone, Dr. Divya, Dr. Jayamala, Dr. Archana, and thank you so much, Dr. Prashant, for joining us and giving us
Thank you very much because it was a wonderful session. I would like to, participate every month also.
Oh,
So you can always forward those.
Sure. I will send you the link, sir. Don't worry, sir. Next month we'll have another challenging topic.
Thank you. Yeah, sure. Thank you. Yeah.
Thank you, everyone. Thank you so much, Dr. Kameshwari, Dr. Tamima.
Thank you, ma'am. Thank you for the
Thank you, Karpakamal. Nicely done.
Thank you.
All the three speakers really did a very good job and more than what everyone expected. And it was really a good discussion with good inputs from Dr. Sir and also Kameshwari ma'am looped in. And thank you so much, everyone.
Thank you so much for joining. Thanks a million.
Thank you.
Happy evening. Bye.